now we are going to have Steve Filler and the next panel come on up. Steve is our Chief Operating Officer at symplr.
So this one's going to be interactive. So I would really encourage everybody here to start thinking about questions. We're talking about the balancing act. And so how do you blend the consumerism, rev cycle, financials, and clinical care as well? But please do ask questions. I only have one question for each of the panelists, and it would be a lot more fun if you guys start asking questions as well. So there are mics on both sides of the room. And so as we get into this, let's pepper them with questions and scare the hell out of them. So why don't we go ahead and introduce ourselves? Sandra, you want to start?
Yes, I'm Sandra Johnson, and I'm the Chief Revenue Officer at MedStar Health, and we are in Virginia, D.C., and Maryland. We have 10 hospitals, 7,000 physicians, 700 locations.
Hello, I'm Taylor Hamilton. I'm the Chief Consumer Officer at Ballad Health. We are headquartered out of Johnson City, Tennessee, and serve 4 states, Tennessee, Virginia, North Carolina, and Kentucky. We have 20 hospitals. We had 21 hospitals, but if you watch the national news during the hurricane, we lost one of our hospitals during the most recent hurricane that hit Tennessee. That was terrifying, and if you want to hear any war stories from that, I'm happy to reluctantly share those. But we serve about a population about 1 million people, and really love what I do.
Good morning, I'm Katie Barr. I'm the Chief Nursing Informatics Officer for Advocate Health. You heard from Amy earlier about the size of our organization. I think the thing that I focus on, because I do support all of our clinicians and our nurses, we have 43,000 nurses that are taking care of our patients. So when I talk about things, I focus on nursing quite a bit, not because of my title, but because that's our biggest population.
Thank you. So I have the unique pleasure of having been to all 3 of the facilities, all 3 of the systems. I actually was an employee at Advocate many, many years ago, and I've worked at both of yours as well. And so the panelists are at 3 of the most preeminent facilities and health systems in the country, and it's pretty impressive. And Sandra, I'm going to start with you. So for those who don't know MedStar, it's really at the tip of the spear of what's going on. It's the only health system that has 2 facilities in the DC metro area. And so as regulatory changes come, MedStar gets hit first, just to be really direct. And so what happens there then bleeds to the rest of the healthcare systems. And so what they're learning through experience really have to mitigate is a pretty significant challenge. And so Sandra and I have been talking about this, and the tariffs are hitting you guys very hard. And so Sandra, you want to talk about kind of your experiences? You just had an offsite going through what you guys are going to do with supply chain, how you're going to mitigate some of this. You want to talk about some of the experiences you have? And I will also say Sandra is probably the rev cycle leader with the biggest heart you've ever seen. So part of her stories, I hope she talks about the oncology side of it, because it's pretty sweet.
Yeah, I'll start with that side of it. You know, when they came in and started shaking up the government, we didn't realize how much impact it was going to have on us. We actually have 3 hospitals in D.C., and when you lay off 100,000 people, a lot of them are going to our hospitals. And so we started to get all these phone calls in my customer service area because people were halfway through their cancer treatment, and now they had no more benefits because they had been laid off, and it only lasts through the end of whatever month you get laid off in. And so now they were looking for help. And we're trying to figure out what are we going to do to help these people. You know, we barely got a margin now. You know, we're just recovering from COVID and starting to get margins back, and now all of this is happening. And then we had the other half of them were calling because they already had payment plans set up, wanting us to hold the payment plan for X number of months so they could have time to find another job. And so we are caught up in that right now. And so I'm letting my people know, you know, hold the payment plan as long as we can, do this, do that. You know, we had a meeting to try to strategize around how could we possibly help them and still keep some kind of margin. And so we are looking at vendors. We have some vendors that help with copays, so we're going to say, can you help with actually paying the premium on the COBRA account? You know, so we could try to at least get the people that are in the middle of cancer treatment through their treatments or something, and so that they won't have to worry about that. You know, so it is really difficult to come up with ways that we can help that number of people at one time and still be able to, you know, I'm financially responsible for that hospital too. I've got to keep them running also. So that's been very difficult. And then with the tariffs and how the supply chain comes into it. And so we had another strategy session to try to figure out, what can we do? We could, of course, hoard a bunch of supplies, but you know how that is. Some of them, their livelihood is only so long, so you can't keep them. Those kind of things. So we're trying to look at what's the things that we have to have the most, and what is the longevity. What can we do about trying to, at least get some more of those in before it happens. This has just been a very, very trying time for us, trying to figure out how we're going to do all these things and still make sure we can take care of our patients.
Sandra said something to me last night that really hit home, because I was working with MedStar during COVID, and I know the trying times they went through there. And she said to me last night, this is worse than when we were with COVID. And at COVID, they were losing hundreds of millions of dollars a year, and this is worse. And when she said that, it was like, wow, this is, the impact that you all are having to go through is significant. We are gonna try to help you guys with that, but please, if we can help, let us know. But that was a very profound thing she said to me last night. So switching on, what I did at MedStar actually is very similar to what Taylor works on. It's the consumer side of healthcare. And by the way, your title is really cool. As a former consultant, a chief consumer officer is a new up-and-coming title that many health systems are just starting to consider. So can you explain to this group what you go through? The CEOs across the country are pushing on investments in the consumer side of it, but let's be honest, healthcare is a little bit of a laggard. We don't, as an industry, we don't really understand how to actually handle consumers. Forget about patients, but it's also patients, families, kind of all the vendors, all the people that we have to deal with. How do you mitigate and work with them? And so as the Chief Consumer Officer, what's your strategy? How do you work on it? What can this group learn from you and Ballard?
How much time do I have? So yeah, I love my job. It's really neat. Our CEO came to me about 5 years ago and said, I have this idea. Chief Consumer Officer. I was in marketing at the time, and I'm like, wow, what does that mean? And we sat down and we mapped it out and we talked about it, but essentially it's what we all want to do is putting the consumer first, so it's the patient. But we're consumers. We work at health systems, and the physicians are the consumers and the nurses are the consumers, right? So really, how do you become this people pleaser and putting everything at the center? And that's what I get to do all day, every day. So it's really neat. I get to work cross-functionally with departments all across the system. I get to work with great vendor partners, and ultimately what I try to do is on the back side, do all the really complicated things that we work on all the time to make this really super complicated thing that is healthcare easy. Because on the consumer side, all we want to do is Google it and then just get our appointment and then show up and then it's there. I don't want to sit there for 30 minutes and fill out the paperwork. I don't want to get lost getting there. I don't want to fill out the paperwork online and then get to the location and then, oh, well, now you need to fill out these 16 extra forms or whatever it is, right? It just needs to be easy. And on the back end, it's all these complicated things that all the platforms, whether it's symplr trying to make it easier, combining all the platforms, or Epic doing what Epic says they're going to do and it actually works the way it's supposed to, and just making it easy. And I'm not being critical of anyone, right? We've all experienced everything. You get in with a vendor and they promise the sun, the moon, and the stars, and you roll it out that way, and then it doesn't work exactly the way it's supposed to. When I got into my role, it was during COVID, and we had fast-tracked virtual care. And one of my first things was I sat down with our physician leaders and said, talk to me about how virtual care is going. And they said, well, our tip sheet is 12 pages long. I was like, your what? Your tip sheet is 12 pages? I don't want to read anything for 12 pages and then try to go step by step to engage with a patient, right? So it's making things easy. So on the consumer side, what we really are trying to focus on, not only in the healthcare industry, but just in the consumerism as general, is make it personalized and make it as frictionless as possible. And we want feedback all the time. We're getting about 1 million different touch points of feedback every month across our consumer journey. So that's everything from the HCAP scores that I'm sure everyone in here looks at. The quality metrics, there's feedback happening everywhere. Every single phone call is feedback. Every single post on social media is feedback. I actually just 2 minutes ago had one of our executive vice presidents send me a screenshot of a Reddit post and said, "Can you respond to this?" And I was like, well, respectfully, that opens a can of worms if we're gonna start going into Reddit, right? But it's patient feedback and it means something. So real-time feedback, in my opinion, is extremely important because HCAPs are great. I think it's a good bellwether, right? But it's months old. So we sat down a few months ago with our leaders and said, how do we get more real-time feedback, but in actual real time before they get so mad they're on Facebook and it's gone viral and literally half of the community has seen that it took 3 hours to get a cold meal delivered to someone's room. How do we head that off at the pass? And it's super simple, in my opinion, is Google reviews. I mean, we compare ourselves at Ballad. We're comparing ourselves to, yes, our peers. What are our peers doing? We want to learn from our peers. But really, I'm comparing us to Amazon and to Netflix and to Delta. They have got it figured out. It is easy. And I want us to be able to create an experience that it is so easy to consume healthcare that it's not, I have to make an appointment or I have to go do this. It needs to be, I got to order this pair of socks, boom, done. It's going to be at my doorstep the next day, right? So that's why we're engaging the way we are. Well, one of the first things you do as a consumer, whether you have lived in an area your entire life or you're visiting, is you're going to go to a search engine. What are other people saying about it, right? Google is the example I'll use. So about 6 months ago, we sat down with our executive leadership team and we said, we're going to automate a process with a partner we already have that's integrated with our EMR, and we're going to send out messages asking people to leave a Google review. I know that sounds ridiculously easy, and it is, but it's working. On January 7th, we launched a process where at 5 p.m. every day, any patient has been discharged or has completed an appointment, receives a text message prompting them to leave a response. How was your care today? Super easy. It takes them out of our environment to Google, and they leave a response. Every single response is responded to, whether it's a 1-star or a 5-star. We have a team that goes in the call center every day, and they respond to every single response. Our average star rating on January 7th was a 1.3 across 20 hospitals, 220 independent clinic locations, blah, 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 blah. Today, what is today, like end of April, we have a 4.4 is our average star rating. And the ripple effect of that has been absolutely incredible. It's, of course, improving our NPS score in the community. Our brand surveys are coming back that are positive. It's our patients are happier. We're hearing from people in the community that have never utilized our services that their shift of tone has gone from negative to neutral to positive in 3 months just because we're asking for feedback. And it's not all positive. I don't want it to be all positive. We need to act in real time to the 1-stars. So we have a process in place where we're seeing what are people complaining about in real time, and this is happening within 12 hours of them leaving a location. And we have programs in place now where we are sending these out to these strike teams that are going and fixing things that we didn't even know were an issue until 6 months after the fact. So overall, it's been successful. It was a little scary. Our board said, well, what's going to happen if everyone leaves a 1-star and all of a sudden, we have 1,000 complaints every day? I'm like, well, then we have a real problem that we need to fix. So, overall, it's been really successful. And again, it's so easy. Google is public. You can't control it. Anybody, even whether you visited a location or not, you can leave a Google review. So I think it's been a fantastic journey for us on the consumer side. And one other thing I'll mention before I pass it on. Internally, it has lifted our culture, and that was, I did not expect that. When we round now, the nurses are elated. Did you see the reviews that we're getting? And everyone's so happy with our care, and we work so hard. It's great to see the community lifting us up because of all this work we're doing that's finally having this positive impact. And it was something as easy as just asking our consumer, hey, how do you think the job we're doing? Is it good, or do we need to work on a few things? So with that, I will hand it off.
Thanks, Taylor. Katie. Katie's probably the one person in this room who, when I say Minocqua bat, she actually understands what I'm talking about. So Katie, we've heard about the implications of shifting conditions to the market and why the application of consumerism trends is so important to healthcare. The balancing act continues to clinical work where the rubber meets the road. Can you talk about the implications of how all the different changes, all the different impacts that you guys are dealing with, especially with the 43,000 nurses?
Absolutely. I think about change management. There's been such a theme today about change management, and a theme about operationally driven initiatives and IT supported. And what I kept thinking was, we really try to do that, but we forget. We forget because we're in IT and we know better. So we're just going to do it. So I think, this is something that we've been trying to do better, because we do have to listen to our clinicians just like we have to listen to our consumers about what's working and what's not working. We had lots of big challenges, especially in nursing after COVID, with staffing challenges and shortages and burnout and just nurse burden overall across the board. And we've tried several different ways to make that better, starting with care model redesign. I think I heard somebody mention 3.0. That's kind of where we're at too. Like, we just keep trying things, but some things are sticking. I'll talk a little bit about virtual nursing. We have virtual nursing in 29 of our hospitals. It's not done the same way in all 29 hospitals, but that's what we're trying to figure out. What does work best? What's going to give us that increased retention, the nurse satisfaction, that wanting to go to work every day? That's really what we're trying to measure with the different care models that we're trying with virtual nursing. Which brings me kind of to the ROI portion. And Steve and I were laughing about this because he said, well, you're going to be on a panel and talk about ROI. And I said, budget's a 4-letter word to me. So I'm not really sure I want to do that. But laughing aside, I think, proving the ROI on some of the things that we're trying to do to increase nursing satisfaction, decrease the burden on our nurse managers, make people want to come to work every day, there's not always a hard dollar ROI. We're not going to change ratios anymore. We've done that. I'm not going to do that again. We need to find ways to bring the joy back, as was mentioned earlier. And that doesn't always mean dollars and cents. You can look at retention. You can look at, is it going to decrease length of stay? But is that what caused it? It's just not easy to get that true ROI. For virtual nursing, we're looking at it. We're actually going to light up one of our hospitals with cameras in every single room, and it's going to be virtual acute care. So we're not just focusing on the ROI from nursing to justify the expense. It's the ROI from other programs that we can implement in that virtual way, which is exciting. We don't know what it's all going to be, but thankfully our finance department finally gave us approval to move forward, and they're taking a chance. So, I think we have to get, somebody's laughing over there.
There's like, no way.
Yeah. 5 years, Dr. Chaudhry, it's what it's going to take. I think that we are working on how are we redesigning care. We're a private preview from Microsoft for ambient listening for nursing. Going back to the change management part of it, we really try to think that we don't do anything for nurses without nurses. But I think on this one we missed the mark a little bit because it's not about the technology. Microsoft came in with their implementation methodology and how they wanted to do it. And I have a human factors engineer on my informatics team, and she was like, we got to do something different. And we didn't, because with Microsoft, it was like, wait, go live because of their development, which is fine. It's exciting that we're doing it. We're learning a lot. But I think we have an opportunity to prepare our nurses better for the future of the technology, not just ambient listening, but understanding, I like to call it augmented intelligence and not artificial intelligence, but help nurses understand and accept, nurses aren't afraid of change. Nurses are very resilient. We heard that earlier. Nurses will find a workaround for anything. They'll make anything work. But how can we help them understand and see the value in what we're bringing that may not be dollars and cents?
So this is where I was going to open it up to the audience. But if you, anybody, Bueller? If you don't, yeah.
How you manage The inevitable complaints or concerns from, and I'll speak as a physician, from physicians who say, well, they complain about the parking or they complain about X that I have no control over. And we shouldn't be as transparent about these reviews, even though with Google reviews, it's out there, you can't do anything about it. Typically, that's a small segment of the physician population because the majority of these reviews are positive, but we always focus on the negative. So just curious to see how you've managed that. Is that part of the strike team business or what they need to manage?
So we do. We have a team that goes in and with the 1, 2, and 3s, because we consider a 3, even though it's middle of the road, we consider it negative and an opportunity to improve. And then we divide it up in what's clinical and non-clinical. And then we validate negative reviews to make sure, have you actually been there? Are you an actual patient? So we work with risk and compliance on that. And then from there, we drill down into that subject matter expert. It sounds like it's super complicated and takes a long time, but it really doesn't. I mean, we're hardwired now. And some are the parking lot, and it was hard to find. And that's just a one-on-one conversation, actually. We send an email, and then we get this person on the phone. The average length of a phone call for a negative review is 4 minutes and 28 seconds. And we actually have patients going in and changing negative reviews to positive reviews. And they say, I actually had somebody from the system reach out, and they talked to me about X, and this is great. So while it still wasn't a great experience for them, we were able to explain to them why it was not a great experience for them, and we've seen some of those flip, but not every story is great, right? I mean, there are things that happen that are not perfect, but we really want to use those as opportunities to improve. I would say something that's been really interesting to me is that every review is written. So we're running all of the reviews, thousands of reviews a month through different language models, and I'm asking it to pick out themes, and there's themes coming out of specifically our emergency department, because the one complaint every single person here probably has about your ER is the wait's too long. Well, I already know that, right? And that's something that we're all trying to figure out. But there's 2 themes came out in the last 60 days that are 100% patterns that we've never identified before, that we are now coming up with solutions on because we had enough negative reviews across our 20 locations to say, you know what, this is a problem and we need to fix it. It wasn't patient safety, but it was certainly something that's addressable. So our physicians have been on board. We actually went to clinical counsel and talked to them about this idea before we launched it to make sure we were going to have support. Because the physicians and the nurses are critical to the success of this program, and they're the ones actually talking to our patients now too, saying, hey, we're going to send you this link, and you really need to tell us what worked and what didn't, because this is how we're driving our strategy moving forward on opportunities to improve.
Great idea. Thank you.
While we're waiting for another question from you guys, all 3 of your systems grew through M&A. So you either merged or you acquired hospitals along the way. That leads to, we've talked about change management a lot, but that leads to a lot of chaos, a lot of confusion. How do you guys, I'm going to open it up to all 3 of you, how do you guys mitigate some of that change management, the cultural change, and find what's the best practice to be able to drive an enhancement throughout the whole system?
It's everywhere I go, I have to do some change management. Getting pretty good at it now. So, usually when I get somewhere, they haven't changed in 40 years, believe me. And then I have to try to figure out how I'm going to get them to change and feel like it's all right to change. And so I start long before we even start the process of looking at workflows or anything like that, getting them prepared for the fact that we are going to have a change, and change is good. It's not a bad thing. And then you have to communicate continuously. I communicate all the time. Constantly I'm communicating with my folks because I don't have professional staff. I have line staff and professional staff. So your line staff hears it differently than your professional staff does. And so I'm constantly, because I have that line staff, I'm constantly telling them what's going to happen, how it's going to impact them, how it's going to benefit them. And I'm constantly asking them for their input. And so so we have went through this. I've been going through change management for 2 years now, because not only did we have business transformation, we had revenue cycle transformation, because they really didn't have a revenue cycle. They had a back end, but that was it. And so bringing all those people into revenue cycle and and trying to standardize processes and centralize some of them and building centers of excellence took a lot of work and a lot of change, and our scores have not dropped at all. Our scores with the patient, the employee survey, we have stayed at the same level. And I have 1,600 comments though, but I do read them all because that's what helps me to know what we need to do next. But you have to constantly be communicating, constantly letting them know what's going on, what's coming down the pike. You know, this is how it's going to benefit you. You may not be doing the same job, but you will have a job. You may not be doing the same thing. We have to change what you do, but you will be here. You have to keep on telling them, because once that anxiety builds up, that's when you have problems. So you have to continuously communicate, let them know what's going on. I have a newsletter. I have a monthly a town hall meeting, so I'm constantly talking to them. And that has allowed us to go through all this change and not have any major, we had the little hiccups here and there, but nothing major has happened.
Go ahead.
Thank you so much for your great discussion here. I was curious, as we are talking about Healthcare Balancing Act, one of the major issues that we are dealing with is the balance between value-based care and pay for service. Even though we have value-based care, it's been not really as successfully implemented. We are still, of course, more of pay for services. So I'm curious what your organizations have been doing to address it. And I would love to learn, even technology-wise, how we can do a better job in enforcing some of these important aspects of operation. Thank you.
You need to come visit us. Maryland is the only waiver state.
Yes.
Yes, and so
It's true.
we have to do value-based care. We don't have a choice. It's
That's
the only way
true.
you can get paid. So
Yes,
we do a lot of
that's-
value-based care.
Yeah,
And this continuum of care, because then now have put it all together, so all your revenue is tied up until you've taken care of the patient from cradle to grave. And so we're pretty good at it. So you need to come to Maryland, and I'll walk you through all those crazy things that they
Right.
do.
We do, of course, want to learn, but again, the other states are still not following
I know,
that great.
we've been doing it over 20 years, and nobody's following it. But it is a different way to think about things. So it is all about, the continuum of care and making sure that you can take care of that patient from beginning to end. And so everything we have is designed around that. The technology, everything is designed around making sure that's accomplished.
Yeah, I just want to add really quickly, and I think this is something that before I was the CNIO, I led clinical applications for the organization and an organization before that, and I was very involved with our population health management folks. And what I think is the most important is that yes, you have value-based care and you have risk contracts, but your EMR should reflect the best care, period, not just the best care based on payer. And I think that's, sometimes that's hard to do, to think that way, because you're going to get more money if you do something else. But I think that's the most important, is treat all patients like your money's at risk. Sorry, that was the nurse in me.
I like it. Please.
So I have a comment and a question. I'm Terry Halen-Bremer. I'm the COO from TriHealth, which is in Cincinnati. We are a value-based organization, and my comment is I love seeing a chief consumer officer. We've been dealing with consumerism for a decade. We're actually doing it a little bit different in that we are using psychographic segmentation to actually drive our behavior and our outcomes. And so we're now at the point where we're trying to learn how to scale it using some technologies. So I'm happy to share our story with anybody that's interested, but we've got really good data around this. My question is, we're in such uncertainty of times, and in my COO role, I've got everybody being rigorous on their expense management and their revenue growth, but we also need to innovate. How are you balancing those conversations in your organizations? Because I think it's a really great time to innovate despite the challenges.
It's interesting timing because we're in the midst of budgeting right now and we're feeling the squeeze just like everyone. And I went back to my team and said, let's look back at all of our vendor partners that we have And everyone's evolving constantly. I mean, symplr has this new wonderful product, and Epic's rolling out all of these new things with my chart for on the consumerism side. And we're already paying for these. It's already in our contract. Let's go back and clean slate like we've never had an engagement with this vendor before, even though we have a contract. And figure out what do we have, what do we need, and where's the gap. And for leading into this next fiscal year, actually the next 2 fiscal years, our plan on at least the consumerism side is to not bring on any new vendor partners. It's to leverage our existing partnerships and optimize those current contracts, because there's all of these tools that we're just not using. So to your point, we've identified in the patient journey mapping and all of our different research and everything else, here's what we want our consumer journey to look like. We have a 3-year roadmap. So we're taking that and we're butting it up against all the different vendor partner and solutions that are out there, from what we own and what different areas of our organization like IT own, with whether it's Epic or Microsoft. And we're doing crosswalks to the consumer journey to what we're already paying for to see how we can optimize it without adding additional cost to the health system.
I think that we're doing the same thing and trying to be an Epic first for our clinical platforms. If Epic can do it, or do it at least 80 to 90% as well as a niche vendor, we should go with Epic because they're going to get there, right? That wasn't an Epic commercial. But that's the philosophy that we're trying to take, just to control expenses. And I think that's where innovation is not always that bright, shiny product that's coming down the pike. Innovation is using what we have better, and how do we innovate with all of our major platforms. I think the other side of the equation in being able to spend some time with innovation is a really good governance process, because not everyone can do everything. IT can only do so much, but we have to make sure that our clinicians and our operational partners are at the table. So we do have leadership councils in each of our main pillars of applications that we entertain, and there is a final decision made by that group. We also have AI governance that's worked into that, where we have to make sure that it's responsible AI if we're going to introduce it. So, I mean, you have to be picky. You can't do everything, but that will let you innovate in other ways, I think.
And we started about 3 years ago. I think Mayor started there, and they have an automation group, they have a digital group, and they have an AI group. So they already have all the pieces in place. Now, I don't know how far they had gotten, but when I got there, they didn't got very far. But they're now starting to pick that up some, and now we're starting to really put a lot of AI in there, a lot of automation in there. They had a lot of automation, but they had the wrong partner with them. And they ended up, y'all know what happened. So they ended up out there by themselves, and I gave them the platform we should use at the last hospital I was at before, and now everything is on our own platform. And so now we're doing a lot of AI because we had such horrible systems, so we had to figure out something. And now we're getting ready to do a system conversion, so we'll see what happens next.
Yes, sir.
Yes, hi. My name is Randy Farmer. I'm with Delaware's Health Information Network. We're like central nervous system connecting health systems throughout much of the Mid-Atlantic. I'm fascinated by the touch points that you're doing and the information that you're garnering through the customer experience. We're actually involved in a customer experience project as well, a first real series foray, understanding where our customer touch points are and where the pain points are. And the real important thing that I found with this was I had to get buy-in from my CIO and our CEO to make sure that this stuff is going to be actionable. Because as great as the insights are, execution is the chariot of genius, right? I mean, what good is it if you can't do anything about it? So in a large organization like yours, how do you ensure that you can take action on the priorities that you identify, and that all parties are going to be moving in the same direction to affect meaningful change?
Yeah, that's a great question. So what we've done, and again, this was launched in January. Right now, it seems to be working. As we did work with the CEOs because there's information overload. The number of dashboards and data and reports that hit all of our inboxes every day is just overwhelming. And I sat with our CEOs and said, what is important to you for action? Coming from corporate, what would be actionable? And it's something that comes once a month with highlights of this is what's working, this isn't working, and suggested things that we need to be focused on. I know that sounds really easy. So that's what we've started doing in February. We send out, we do individual reports for all 20 hospitals, and then we do service line breakdown reports for our medical group. And sometimes there's a theme that's enterprise-wide, like some of the issues that we're seeing, opportunities for improvement in our emergency departments. But other times it's localized. And it might be localized down to a department level. So it's like department on this floor, we've had 25 different complaints about X. And then it's providing these leaders with, okay, thank you. So first of all, this is shared in a private setting, one-on-one. Then they take it back to their teams. They're doing their rounding and taking it back to their individual boards. But then they're creating action plans from the data that we're providing. And again, it's once a month. It's very clear. It's concise. And they know it's going to look the same every month. So that seems to be working right now. And again, we're 90 days in, so we could talk again if you want to email me or call me. We could talk again in about 6 months. But right now, this seems to be working, but it needs to be easy to digest. And that is the number one piece of information that I got back from our leaders and our clinicians.
We have time for one more question. Go ahead.
In my health system, we are expending an inordinate amount of resources with denials and prior authorizations. Can you share a little bit about how you're handling that?
Yeah, we're doing the same thing, and so that's what we started to put AI in first, was the denial piece of it. So it creates the letters for us, and we're looking at each of the different types of denials and seeing if we can use AI in there somewhere. And so that's what we started out looking at, was denials first. And prior authorizations, that we haven't really gotten into it as much as denials, but we're starting to try to see what we can do there too. Because, we need to know things that, like I said, we have very old systems. That's why we're going to do a system conversion. But right now, I got a green screen. I put a young kid on there. They're like, why is that green? Why can't I use my mouse? That's how old our systems are. And so I'm trying to get anything I can get right now. But so we started with the now piece, and that's working pretty good. Everything that we've tried to put AI in, we've been able to put it in. And so now we're going to start looking at the prior ops piece of it to see what we can do there. I'm glad that they've got the changes coming with CMS. I don't want to get my hopes up, though. You know how that is. We always think something's going to change, and it really doesn't. But they do, they got this reg that just came out saying that they're going to have to give it to us 7 days maximum. They got to tell us exactly why they denied it. All of these things are saying it's going to happen, but I will believe it when I see it. But they'll figure out some kind of way to mess it up, I'm sure. but at least they'll start to give us some of the things I was going to use AI for to do. I was going to have them, now they're doing the same thing. Because I was going to have AI go out and, all the websites and actually bring down exactly why they denied it. Because, they don't give it to you in the remit, so you have to go somewhere else or call somebody in order to find out exactly why did you deny this. And so now that's supposed to be one of the criteria. They have to tell us exactly why, have to tell us when they denied it, have to tell us what other documentation was needed. All of these things is what came out of that last reg. But, just like when what was the standards, the ANSI standards came out, I was so excited. I said, oh God, we're going to standardize everything. And every payer interprets it a different way. Every payer uses it a different way. And that's why I'm afraid this is going to happen to this too, is people will figure out a way to not use it the way it was meant to be.
And on that note, I would like to thank my colleagues and the panelists, please, if you would. Thank you guys very much.